Kia ora tātou. I'm Cathy. I'm a GP working at the 502 Rangatahi Youth Clinic in Pororua, just north of Whanganui-a-Tara. Over my years working in primary care, I have supported many patients with ME/CFS, and their resilience and courage has stayed with me. People with this debilitating condition have historically struggled to access even basic pathways for health provision, and at times are met with a lack of knowledge, a lack of understanding, and even a lack of empathy. I feel super privileged to be a small part of World ME Day, raising awareness of the condition and discussing how we as health providers can better support our patients who live with it. Thank you to the wonderful people at ME Awareness for the opportunity and also for the immensely important work they do in this space. Over the next few minutes, I'm going to give you a brief overview of the diagnostic criteria for ME/CFS. We will look in a wee bit more detail at one of the cardinal features of this condition, post-exertional malaise. I'll show you a clip from a patient talking about what post-exertional malaise is like for her, far more eloquently and poignantly than I ever could, and then discuss how we can support patients to reduce the impact that this symptom can have on their lives. Lastly, we'll look at some key messages and a few resources for those who want to learn more. So what is ME/CFS? Well, according to the National Academy of Medicine, formerly the Institute of Medicine, it is a serious, chronic, complex, and multi-system disease that frequently and dramatically limits the activities of affected patients. Over the years, a number of diagnostic criteria have been developed, many for research purposes. For clinical use, I recommend the Institute of Medicine's ones from 2015. To meet a diagnosis of ME/CFS, they require the presence of post-exertional malaise, which is an abnormal response to physical or cognitive exertion, a substantial reduction or impairment in the ability to engage in pre-illness levels of activity, accompanied by fatigue, unrefreshing sleep, either cognitive impairment and/or orthostatic intolerance. And additional symptoms may be present and can be really relevant for a treatment plan, but are not considered to be diagnostic. The focus of my talk today is on post-exertional malaise, because firstly, when we learn to recognize this symptom, the diagnosis of ME/CFS becomes much easier. It's not a symptom we see anywhere else, so many of us won't have a great understanding of it. Secondly, because we know that managing post-exertional malaise successfully is a key contributor to patient quality of life. And lastly, because many long COVID patients also experience post-exertional malaise, and it will come as no surprise that we are expecting ever-rising rates of this to affect New Zealanders in the coming months and years. So what is post-exertional malaise, or PEM? Well, PEM has only been documented in ME/CFS and now in a subgroup of long COVID patients. It's an abnormal response to normal activity, and it presents as a disproportionate and prolonged exacerbation of baseline ME/CFS symptoms and as a reduction in the ability to function. Patients report a wide range of symptoms and feeling sick or poisoned. Post-exertional malaise is very different from the sort of muscle soreness and exhaustion we all experience after a little too much exercise. Post-exertional malaise often only sets in 24 to 72 hours after an exertional trigger. For some patients, it sets in sooner, but only peaks 1 or more days later. It may last for days, weeks, or much longer. And sadly, episodes of post-exertional malaise can result in a permanently lowered baseline function. Post-exertional malaise is part of what's known as the push-crash cycle. On a better day, a patient may push themselves to do a little bit more, but then crash afterwards, sometimes taking ages to recover. The impact of post-exertional malaise may be able to be reduced by careful activity and energy management, where exertion is kept within what is known as the individual patient's energy envelope. This type of management is often called pacing for ME/CFS, but be aware that this is different from pacing programs that are used, for example, in chronic pain. We'll revisit this in a few moments. We are all familiar with post-exertional fatigue and exercise tolerance, as these occur in many conditions. However, there are important differences between them and post-exertional malaise, both in terms of the type, but also the timing of the symptoms. In patients with exercise intolerance, the symptoms occur during exercise or very soon after and are clearly related to the exercise. So, for example, breathlessness and muscle aches from walking uphill. Recovery generally takes less than a day. Post-exertional fatigue is similar to exercise intolerance, except symptoms are by definition post or after exercise and may take longer to resolve. This term can also refer to cognitive fatigue following mental exertion, which takes longer than expected to resolve. However, when we look at post-exertional malaise, we see a much wider range of symptoms that are exacerbated by exertion, and typically their onset is delayed. Patients are unable to function as usual and describe feeling ill or poisoned. PEM symptoms are disproportionately severe and very slow to resolve, and in some cases do not fully resolve back to baseline levels. Note that ME/CFS patients can also experience symptoms of exercise intolerance and post-exertional fatigue in addition to their post-exertional malaise. So what can lead to post-exertional malaise? Well, in a nutshell, exertion of any kind beyond the individual's energy envelope upper limit can trigger post-exertional malaise. The energy envelope is a metaphor used to refer to the capacity that an individual has for their optimal level of activity, rest, and energy expenditure. Staying below the lower limit of the energy envelope, the patient is unnecessarily inactive. But when going above the upper limit of the energy envelope, this can trigger post-exertional malaise. And by far the majority of ME/CFS patients operate too closely to the upper limit. How much and what type of exertion exceeds the upper limit of the energy envelope and triggers PEM varies for each individual and also depends on how severe their ME/CFS is. If we look at physical triggers, in mild ME or CFS, for example, this might be exercise such as walking. But in moderate to severe ME/CFS, activities of daily living such as showering may be triggering. And in very severe cases, necessary activities such as chewing food may exceed the envelope and lead to post-exertional malaise. Cognitive triggers might include thinking, planning, reading, or writing. Processing emotional events, both positive and negative, can be triggering. And sensory overload is another, perhaps unexpected way that the energy envelope can be exceeded. For example, experiencing noise, light, touch, smell, taste, temperature, or even vibrations, such as when traveling in a vehicle. Physiological processes can contribute, including digestion, temperature regulation, fighting infections, and so on. And orthostatic energy, used when sitting or standing upright compared with lying down, can also be a trigger. And lastly, multitasking. Even if individually each activity is within the energy envelope, trying to combine, for example, talking whilst walking or thinking whilst in a noisy environment can lead to post-exertional malaise. Triggers cannot always be identified even by patients themselves, and this can lead to them feeling guilty and stressed for having unintentionally exacerbated their condition. As health providers, it's really important we don't add to this guilt inadvertently by questioning what they did to expend their energy. Instead, support patients with the message that ME/CFS fluctuates naturally, even without post-exertional malaise, and that this makes it impossible to always judge one's energy envelope correctly. Also remind them that life has to continue in spite of ME/CFS, and sometimes post-exertional malaise is simply inevitable. One aspect of post-exertional malaise that tends to be under-recognised is that cumulative exertion can also trigger it. It's naturally easier to focus on the impact of single activities, which is what most of the research does, but real life is messy. The delayed onset of post-exertional malaise can lead to patients feeling a false sense of security. Maybe I'm feeling okay, maybe I can continue, in the window between exceeding their energy envelope and the symptom exacerbation starting. These patients may end up in a state of continuous rolling post-exertional malaise because they resume their usual level of baseline activity as soon as they feel slightly less bad but before they have fully recovered back to their baseline, which research shows this can take days to weeks. Effectively, they trigger a PEM episode on top of a PEM episode on top of a PEM episode. Distinguishing post-exertional malaise from exercise intolerance or post-exertional fatigue when the patient is in a state of rolling post-exertional malaise is particularly difficult, but encouraging and enabling a period of rest and observing the effect may help clarify the diagnosis. So, what is the risk of post-exertional malaise? Well, the major one is that it can cause a reduction in baseline function. With enough rest, a return to baseline function is usually possible. However, each PEM episode and each prolonged period of rolling PEM carries a risk of the patient being unable to return to their previous baseline function and of their energy envelope shrinking. This is unfortunately not rare. New patients with little experience in PEM management are particularly at risk, as are patients without the resources to delegate major family responsibilities or financial obligations to others. So, in summary, it's really important for us to learn how to identify post-exertional malaise, as it will help us reach a diagnosis as well as guide our management and support. To clarify whether or not PEM is present, ask about the type, range, and severity of symptoms. Crucially, ask about the timing of symptoms. And lastly, explore the types, range, intensity, and frequency of triggers, looking specifically at the areas we mentioned earlier. I'd now love to share Gemma's experience of post-exertional malaise, which will hopefully bring to life the theory we have just covered. For me, this clip is so powerful and reinforces how impacting this condition can be. ME/CFS has decimated Gemma's life, although thankfully she has experienced improved functionality levels in recent months.
Hi everyone, my name is Gemma. I'm going to very briefly show you what it can be like to live with ME, and in particular how post-exertional malaise can affect someone with ME. A quick background, I was officially diagnosed 2 years ago after 10 years of mild undiagnosed illness. I spent a lot of those years trying to improve my health, mostly doing various health regimes with no luck. 2 years ago, I decided I'd exercise my way back to health, causing a disastrous relapse and progression of my illness that I didn't know I had at the time, and dramatically changing my life. This slide highlights my pre-illness level of functioning. It's how I like to remember things. My life was full, I was busy, active, working with 2 young boys, pursuing 2 careers, and living in Melbourne. So, will you see post-exertional malaise in the clinic? As a clinician, what you might see in the clinic is a patient who is well enough to visit for an appointment, probably having a reasonably good day, often not looking particularly unwell. This is how I often present to my GP. I have moderate to severe ME. My GP has to take my word for how I'm feeling because he really sees me when I'm not well. After my relapse, my illness progressed, and this is my new baseline for the last 2 years. I'm now housebound 70% of my time. I'm no longer able to work. I often am unable to care for the children, unable to cook, clean, do household chores, often unable to do basic things like washing hair, showering. I now use an e-scooter to get around on and are able to walk more than a few hundred metres at a time. Things haven't improved from this level for the last 2 years. It would be really rare for my GP to see me like this, as it's very difficult to leave the house. So now I've exceeded my energy envelope. Things that might cause this, for example, are not being able to get a car park close to school and having to walk, having the kids home during school holidays, going out for coffee. You get the picture. My symptoms are now severe, and to be honest, it's very frightening to feel like this. When I experience post-exertional malaise, I have profound fatigue, slurred speech, unable to leave the bed, difficult to chew food, intense muscle fatigue with weakness. I have arrhythmias, including a second-degree heart block, dizziness. It's very difficult to tolerate being upright, shortness of breath, cognitive dysfunction, unable to tolerate light or sound, and definitely unable to care for the children or myself. So that's just a small snapshot of post-exertional malaise, and my personal experience with ME, I really do hope it gives some insight into how hard this illness can be. This demographic of patients are so unwell, and we really do need all the help we can get.
Now let's take a quick look at how we can support patients with ME/CFS to reduce the impact of post-exertional malaise. The main strategy for reducing PEM is pacing, also known as energy management, activity management, or as living within the energy envelope. The main aim of pacing is to improve quality of life. Note that pacing for ME/CFS differs from the type of pacing used in other chronic conditions. So what is pacing for ME/CFS? In a nutshell, pacing means adjusting your life to stay within your energy envelope. This sounds simple, but doesn't mean it's easy to put into practice. Broadly speaking, pacing involves prioritizing what to spend energy on and choosing which activities to reduce or drop altogether. This may include making life-changing decisions, such as reducing employment, retiring, or dropping out of education. Changing the way chosen activities are done so they require less energy. This may include the use of mobility aids. Breaking activities down into short bursts. Interspersing activity with rest, physical, cognitive, and sensory rest, including rest from screens. Aiming for a balance of necessary activities and pleasurable activities. Creating usually safe and energy-efficient routines for regular necessary tasks, and this can help reduce the cognitive load. And stopping before symptoms increase and taking preemptive rest. Some patients may experience subtle clues when getting close to exceeding their energy envelope, but many don't, so they need to be quite proactive in this particular aspect. Each patient's situation is different, so each patient's pacing strategies must differ. For more detailed guidance, refer patients to a knowledgeable physiotherapist or occupational therapist. It's important that they are aware of post-exertional malaise and the difference between pacing for ME/CFS patients and pacing for other conditions. You can also consider referring them to a knowledgeable counsellor to help with the psychological adjustment to a challenging situation, if it is felt to be necessary and requested by the patient. Consider a regional ME or CFS support group, and we've got a link for this on the last slide. And certainly put them in touch with online resources. And again, we've got a link on the last slide. Pacing can be difficult to put into practice. It requires enormous self-discipline and practical and social support. Difficulties may include having to keep track of all types of energy expenditure, so physical, cognitive, emotional, sensory, physiological, orthostatic, and so on. Having to take into account the natural variability of ME/CFS and a fluctuating energy envelope. A lack of support from social networks, employers, schools, and peers. An inability to delegate responsibilities and financial pressures. And an inability to access work accommodations or invest in energy-saving aids and technology. Health professionals have an important role in supporting patients through these particular difficulties. So what pacing for ME/CFS is not? So it's not a treatment. It's a tool used by patients to manage activity within their limited energy envelope with the aim of improving their quality of life. Many patients find pacing leads to a reduction in post-exertional malaise episodes, which is indeed the goal, and to more stability and a lowering in overall symptom burden. In some cases, it may even enable more activity overall over a day. But pacing can only manage symptoms. It cannot treat the underlying pathology of ME/CFS itself. Pacing is not about gently increasing activity. In this respect, it is different, the opposite, to pacing for chronic pain, which encourages learning to gradually tolerate more activity despite pain symptoms. Some ME/CFS patients recover naturally to some degree and will be able to increase their activity at that point, but increasing activity is never the goal of pacing for ME/CFS. Lastly, pacing is not a prescriptive or fixed plan you make once and stick to. The fluctuating nature of ME/CFS means a lot of flexibility is required. So, how can health professionals provide practical support for ME/CFS patients? Firstly, and importantly, we can provide education about PEM and pacing for ME/CFS and support patients' efforts at pacing. We can offer telehealth consultations by phone, video, or even email where appropriate, as coming to the clinic will be a trigger for lots of people with post-exertional malaise. Consider home visits, especially for severely affected patients. Where possible, offer a quiet, low-lit room with a bed for the patient to wait. Ask the patient what other accommodations would be helpful. Keep appointments short and focus on essential physical examinations. Prepare and/or follow up for the appointment by email. Many CFS ME patients have difficulties with memory and cognitive processing, so having a written record is helpful. Document the patient's post-exertional malaise for other service agencies and purposes. Assist with benefit applications, including the supported living payment, job seeker benefit, and the disability allowance. This is critical. Refer for home help and mobility aids, and connect patients and their whānau with other support services in the community, including counselling and local support groups if desired. Practical support for ME/CFS patients. Family and friends can be encouraged to learn about post-exertional malaise and pacing. Learn about their loved one's specific needs and explore possible solutions to help them meet them. Offer to do or organise someone else to do practical tasks around the house or garden, or provide meals, childcare, and so on. Education providers can be encouraged to offer appropriate accommodation, for example, attending online rather than in person, completing fewer subjects, or having extensions to deadlines. Provide disability support services. Consider referral to health school or te kura instead of attending school in person, and consider part-time tertiary study as a limited full-time student. Employers can be encouraged to offer appropriate accommodations, for example, working from home, reduced hours, flexible hours, a quiet location to rest and change to less demanding duties, and so on. So, our key take-home messages from today. Post-exertional malaise is the cardinal feature of ME/CFS and also occurs in a large subgroup of long COVID patients. Correctly identifying post-exertional malaise is crucial to a correct diagnosis. And correctly managing post-exertional malaise is crucial to patient quality of life. Pacing strategies designed specifically for ME/CFS are the main tools to manage post-exertional malaise. Pacing for ME/CFS is also called energy or activity management, or living within the energy envelope. And lastly, health professionals have an important role in enabling patients to manage their post-exertional malaise and pacing. Don't underestimate how valuable this support can be for those who live with this condition and their whānau. To learn more, here are some great resources for health professionals and patients. And for health providers, some links to continuing medical education around ME and CFS. Thank you so much for your time today. Ngā mihi nui, ka kite.